Hi, everybody. I'm Maureen. I'm a nurse practitioner here at St. Luke's. I'm your moderator for today's presentation. And today we have a wonderful presentation coming from Amanda Patino. She has practiced as a speech language pathologist at St. Luke's Medical Center here in Milwaukee for the past 7 years, treating swallow, communication, and cognition. Specific areas of expertise include flexible endoscopic swallow evaluations, video swallow studies, laryngectomy, esophagectomy, head and neck cancer, trach vent, and most relevant to this conversation, complex dysphagia in geriatric populations. So welcome, Amanda, and take it away.
Thank you. And thanks everybody for attending. This is an area that I'm obviously passionate about, and I always appreciate working with the palliative care team. So it's a great opportunity. So I put together a few slides based on some questions that Maureen sent me, just to give an overview of the services that we offer. My focus will be more on dysphagia, but I'll touch on a little bit on the communication and cognition piece of things as well. And if anybody has any questions, Maureen's going to read out questions for me. I'm also happy to discuss further, offline as well. Okay, so I think my most favorite way that the speech therapy role in palliative care patients is laid out is in the Journal of Palliative Medicine from 2004. And this is a quote, so that's why it says hospice care, but it applies to palliative in general. We're just going to go through these to start out with as just our general role. So first, to provide consultation to patients, families, and members of the hospice team in areas of communication, cognition, and swallow function. And I like this point because it kind of highlights how, even though, speech therapy and other therapies are in general considered rehabilitative, that we really have more of a consultative and facilitative role when it comes to the palliative care patient. And through that role, we have a lot to offer to maximize quality of life at this stage of life. Second, to develop strategies in the area of communication skills in order to support the patient's role in decision-making, to maintain social closeness, and to assist the client in fulfillment of end-of-life goals. So whether that is by implementing an alternative or augmentative communication system, evaluating for speaking values, electrolarynx, just determining the best modality or strategies for communication, and then providing family training to assist in communication. And that can be really vital for these patients, and helping us to manage their pain, their symptoms, so they can communicate what's going on and to help them direct their goals of care at this stage of life. Third, to assist in optimizing function related to dysphagia symptoms in order to improve patient comfort and eating satisfaction and promote positive feeding interactions for family members. This is probably the point that I'm going to delve into the deepest. And I like that it really emphasizes that shift in focus from prevention by aspiration to maximizing comfort and enjoyment of oral feeding. And that it includes how important it is to have family involved, since it's just such an important social and cultural event, eating in our lives. And then last, to communicate with members of the interdisciplinary hospice team to provide and receive input related to overall patient care. So as communication experts, we can serve as a bridge both ways. We can support communication and carry over of recommendations from other providers to the patient and their family. And we can also, we may also discover certain things during our sessions with a focus on communication that should then be communicated the other way. And we're also just really fine-tuned into those cognitive and swallowing changes that might trigger us to say, hey, I think something is going on. There's either progression in the disease process, or maybe there's a bad reaction to medications or something going on here that we need to bring the team back in for another look. So moving on, I just have the one slide on cognition and communication before we jump into more of the dysphagia issues. And this was based on a question from Maureen. What's the difference between a neuropsych evaluation and the speech therapy cognitive evaluation? So, I think, well, both are extremely beneficial, but they do serve different purposes. In general, a neuropsych eval is very diagnostic, maybe diagnosing an underlying dementia, giving an overall profile of that patient's cognition in order to determine whether the power of attorney should be activated. That evaluation informs the court's decision on legal competence when it comes to guardianships and other legal proceedings. And they're more in tune with how current medications or other acute and chronic medical issues might be impacting that person's cognition and assist in determining what the prognosis is for any sort of improvement or recovery. So certainly very helpful to have, whether or not we also have the speech therapy evaluation. When an SLP completes a cognitive evaluation, we are approaching that from a treatment perspective. So we're completing the evaluation not to diagnose, but to qualify, to rate what areas of strength and weakness that patient has. So we might rate how severe the issues are, but we're talking about it in like short-term memory versus attention versus executive function. We're not diagnosing dementia, for example. And we use that information to help to educate the family and the patient on what specific activities might be safe, or what assists or supports might be needed to help the patient participate in these activities. We're trying to identify strategies and compensations to improve, again, participation, communication. So we're coming at this from a goal of maximizing participation through supporting, taking advantage of strengths and supporting the weaknesses, and through environmental modifications, compensations, training. We also are going to reassess. So, patient has a neuropsych eval, they have dementia, they are not competent, their POA is activated. We may see them at that point, and then we may see them in a few months. And because there's been a change in status, to just help the family adjust those strategies and compensations to be most appropriate. So hopefully that answers that question. Both are obviously very helpful. Mm-hmm. So then jumping into dysphagia, I'm going to start with how we evaluate dysphagia. So normally we'll get a consult and we'll complete a clinical swallow evaluation or bedside swallow evaluation. And what that entails is a thorough chart review, clinical interview with the patient and their family. We assess dentition and oral hygiene. We look at cranial nerve evaluation, and then we watch the patient eat in their functional environment. And really at that point, it's a screen for dysphagia. And if we do have concerns, we would move on to an instrumental evaluation. And the instrumental evaluation is going to allow us to actually assess the biomechanics of the oral pharyngeal swallow function and guide our interventions. So what is the role of these assessments in the palliative care patient? Well, I think most frequently when goals are unclear, that instrumental can be extremely helpful in better defining risks, giving those treatment options, forming a prognosis. When goals are already established, be more comfort focused, then that clinical evaluation may be enough. We may not need to know if they're aspirating. We may be able to make some suggestions for how to improve comfort just based on the clinical. However, that's not 100%. Sometimes that instrumental will still provide guidance on how to make that patient most comfortable with their oral intake and to support them in that way, identifying strategies or compensations or just seeing what is going well. When I say instrumental evaluation, we have two modalities that we can use. The video fluoroscopic swallow evaluation, otherwise known as the modified barium swallow study, or the flexible endoscopic evaluation of swallow or FEES. So one of the other questions was when do we use one versus the other? And there are a lot of indications, contraindications, pros, cons of both tests. So it is usually a process to figure out which is the best. But I wanted to just kind of touch on why we would use one versus the other in the palliative care patient from a comfort perspective. So if I explain to you with your intact cognition and sensation that your options are to go for an x-ray where you are going to have to swallow some barium and we'll take pictures of your swallowing, or I can put a camera in your nose, most likely you're going to pick the x-ray. That just sounds a lot more tolerable. But if we think about it from the perspective of a patient who maybe is confused, maybe it's a lot of work to transfer, then we have to think about it a little bit differently. So for a video swallow study, we're getting this patient out of their bed, out of their room, bringing them down to the fluoro suite. They're going on this trip, entering a room they've never seen before. It's a strange room. There are usually 3 or 4 strange people in the room. There's a big machine coming around them, and then we're putting things in their mouth that they do not want to swallow. So it can be a pretty stressful evaluation for those patients anyway, and it's COVID. So we're going to stick something up their nose anyway, because they need to have a COVID test before they can go to radiology. For the FEES option, what we do is we take a flexible laryngoscope, we pass it transnasally just above the pharynx, and we directly visualize the swallowing that way. And what's nice about it is we can do it at bedside. We can bring the equipment in, family can be there, we can have family feed them their preferred foods, something from home. It's calmer, they don't have to transfer. And we have to remember that many of these patients have just globally reduced sensation. So it actually doesn't bother them that much usually. I always start with, we can stop at any time. Sometimes we don't know what we're going to get. I might put that scope up to the nose and I might have to dodge a punch. That's happened. But most of the time it goes pretty well and the patient tolerates it really well. And I can also say from personal experience, I'm the trainer for the FEES program here and thus the guinea pig for all the people who don't know what they're doing. I've been scoped dozens and dozens of times. I've scoped myself. It's really not that bad. It sounds bad, but it doesn't, it's really not that bad. So I think that family appreciates hearing that too. So in a palliative care patient, if we can do both, if they're both an option, I would talk to the family about that and we'll figure out what would be the more tolerable exam if either. Another question was how we determine the safest possible diet. That's a broad question, but the simple answer is through an instrumental. If safety is the concern, we need an instrumental. Moving on, so goals of care, when we are discussing especially options for oral feeding or tube feeding, palliative on board, hopefully, then how do we kind of divvy up what we're discussing? What does the speech therapist cover? What does the MD cover? So I'm going to start with what we don't cover. I think that's easier. So we defer to the doctor for overall medical prognosis, and that then informs our options that we give the patient as well. We don't recommend a tube feeding because we don't know if they're medically a candidate for tube feeds. Can they undergo the sedation? Can they stop their Plavix for long enough to place it? Do they have ascites? Is it even possible to place a gastric feeding tube? We don't necessarily know those things. So we defer to the doctor. Is this even something that's on the table? We also don't know the specific type of feeding tube that would be placed, or the procedure that will be used to be placed, or the risks of that procedure itself. So those things we defer to the doctor. And then we also do not say absolutely anything about code status. So that's entirely lapse. And, I think often the aspiration risk will be a factor in that discussion, but we don't discuss the code status. So what do we cover? Really anything and everything under the umbrella of feeding, nutrition, aspiration risk, and a little bit with cognition too, actually. So I like to start by kind of dual recommendations. What would a rehabilitative path look like versus what would a comfort focused path look like when it comes to oral intake, and how would that differ? I would provide education to the family on the patient's risk for aspiration pneumonia with an oral diet, and get into a little bit some of the factors that play into that. Their ability to meet their nutritional needs via an oral diet, risks and benefits of modifying the diet, and risks and benefits of tube feeding. So this is as they relate to aspiration and nutrition. So this does involve quite a bit of myth busting often. I would point them to the American Geriatric Society and the Alzheimer's Association position statements on tube feedings. I would explain why it increases risk of aspiration pneumonia in many populations. I would explain why it would not necessarily improve nutritional status, even though we are giving the calories, that they may not have access to them. I would touch on cognition, because usually I'd be pretty aware of their cognitive status. Are we concerned about them then needing restraints of some sort with the tube feeding? What are the alternatives? Can we provide some patient-led feeding for comfort, hand feeding? Comfort feeding is also known by a free water protocol. Most of the time, families I find are just really worried about starving their loved ones. They think about what they would be feeling if they were not eating or drinking. And so we also get into a little bit about the pathophysiology of nutrition and hydration at the end of life, and try to provide some reassurance that that's not actually what's happening and why. And we go into other ways of nourishing. And this falls under us because it's not safe and it's not comfortable for the family to be trying to force feeding patients when patients don't even want to eat at this point. So how can we look to the patient? And this is communication for cueing. When do they want to eat? When do they want to stop eating? And how to interpret that. And then provide other ways of nourishing. How it seems like second nature to us to do oral cares, but it's weird to do oral cares on your mom. So how do we comfortably do that? How do we dip the swab in the biotin and just moisten the mouth? Maybe it's not even anything to do with the mouth. Maybe we're just having them use some lotion and rub their hands and feet, other ways to kind of interact on that kind of physical level with their loved ones. So we do get into a lot of things. Oh, I forgot one other thing we defer not to the MD necessarily, but to the RD, the registered dietitian, what the caregiver burden is for tube feeding itself. What does their protocol look like at home, and what kind of work would that be? So
maybe before you move on to a question, if I could interject.
Yes.
Ruth asks, can you explain why they aren't experiencing the suffering and starvation at the end of life?
Yeah, that's a great question. So, this is actually one that I will briefly cover, and then I may ask the dietitian or the doctor to go over again, just because it is something that, I understand, but it's not my main area of expertise. But, as the body begins to shut down, you don't necessarily feel that same hunger, you enter a stage of ketosis, and you don't get those same signals to your brain that you're hungry. And then if we feed you anyway through a tube or otherwise, it may actually cause you discomfort and dehydration. Actually getting into a state of dehydration can have some anesthetic effects. And then if we, again, force the fluids, then we might be dealing with things like edema. We might take away from those kind of amazing natural processes that the body does to ease the dying process. So again, I just it's not super detailed what I give, and I might point them to some resources. And if that's the main concern, have the dietitian and the doctor cover that in a little bit more detail. But I usually keep it, pretty simple. When I'm educating family, don't really want to know the chemistry behind it, which is good because I don't know it all. So does that answer the question?
Yeah, I think so.
Okay. Any other questions at this point? Okay. So the next slides I'm just going to go over really quickly. I'm probably running out of time here anyway, but one of the questions was, how do we prognosticate? How do we determine risk of aspiration pneumonia? How do we determine if the patient's going to get better from a swallowing standpoint? We're looking at a lot of the same factors as you do for prognosis. What is dysphagia? Isn't a diagnosis by itself. It's not a standalone diagnosis. It's a part of another disease process. So what is acutely worsening their dysphagia and therefore might improve versus what is a chronic baseline or progressive dysphagia and maybe a little less treatable. What's their baseline nutritional status, their ability to participate in rehabilitation, age, overall medical prognosis. And then we're looking at what we know from our literature and some of the pulmonary literature, critical care literature on what overall risk factors are for aspiration pneumonia. A big one that's really just like visually nice to show families is the John Ashford's 3 pillars of aspiration pneumonia, which essentially gets at the point where aspiration is necessary, but not as sufficient to cause aspiration pneumonia. If you are only aspirating, then nothing else is wrong, you are not going to get pneumonia, almost certainly. So there have to be these other factors, and he groups them into 2 other pillars, one of which is overall health status, and the other is oral hygiene. And he has a nice little chart that lines out if you have 1, 2, or 3 of those pillars, are you at a no, mild, or high risk for aspiration pneumonia. There are also other factors, dependency on oral feeding, dependency for oral cares, which kind of goes with the oral cares, mobility versus bedridden status, cognition. There's a lot of other things that we know, but because we can't give a percentage. We can't say, yes, you're probably going to get aspiration. There's a 50% chance within the next 3 weeks. I wish we had some sort of magical calculator, but the best we can usually do is kind of lower high risk or hardly any risk. And that's, I think, a big reason, going back to that discussion on goals of care and code status, where this is just a piece, because we don't know if someone is going to develop aspiration pneumonia. All we can do is try to mitigate that risk and figure out how that plays into the overall disease process. So one other little note on esophageal involvement, which was another question. Prandial aspiration is not the only source of aspiration. So we do look at kind of the whole GI system. Really, our focus and expertise is in the oral pharyngeal swallow, but we do especially pay attention to esophageal function. And we can have a beautiful, perfect oropharyngeal swallow, and if the esophagus isn't working, we're still going to have problems with nutrition. We may still have problems with aspiration pneumonia. So just looking at all of the factors there, but we do not directly assess the esophagus. That is a GI. So, and then last, I'm actually not going to answer this question very well, probably, because the question was, what are the different dysphagia diets and why are they recommended? I'm going to just keep it simple where they vary a lot facility to facility, but we have this initiative, IDSI, International Dysphagia Diet. Advocate Aurora is switching to it currently, and it's being adopted around the world. So hopefully the diets will be a little bit more universal soon. And there's the website if you want to check out what those diets are. Usually we're talking about either thickening liquids or in some way modifying or softening solids, or both. And we would recommend that primarily based on an instrumental, hopefully. But we would also consider behavioral, environmental, cultural factors, their risk of fluctuation. Is this somebody that their respiratory status is all over the place, or their alertness is all over the place, and how that might impact our recommendations. And we just try to do the best we can, see what they'll agree to modify anyway. So, and that's about all I have. So that was a lot, but
it was great.
Let me know.
There are a couple questions in the chat here. What is the free water protocol you referred to? Dr. Ramelfinger asked that question.
So the free water protocol, the Fraser water protocol has been around since late 80s. And it was a protocol initially developed due to my favorite word of non-compliance with dysphagia diets. It was developed with a team of critical care doctors, speech pathologists, and pulmonologists, and probably some other people that I'm forgetting, but it essentially considers the fact that the body is made up to 70% water. The lungs are actually really good at absorbing water, clean water. And therefore, if we know somebody is aspirating or is an aspiration risk, then perhaps we can allow water in the selected patient and not have any aspiration pneumonia as a result. So the protocol emphasizes greatly oral cares because the water is not a problem, but if you are bringing oral pathogens from the mouth along with that water, that's the biggest problem really in developing aspiration pneumonia. So it involves nursing education, completion, patient selection for who would be appropriate for that. Then, making sure that we're completing those oral cares. The water is given between meals if they're also on an oral diet with a delay to make sure that any oral and pharyngeal residue has been kind of flushed through and we have a chance to do oral cares, and then they can go back to water between meals. It's something that's available at St. Luke's in the inpatient rehab setting, and then at many subacutes. Currently, we do not do the free water protocol on acute. Technically, we don't have the ability to educate all of the nurses that would be needed to implement it properly. And many of our patients would be too acute to be candidates. But it's something to consider if we're thinking about NPO more long-term, can we at least allow water at the next level of care?
Great. One more question. Any exercises to strengthen the muscles affecting the swallowing in older, frail adults, possibly close to end of life, or a possible handout to share? If you could.
So as far as exercises, exercises are also something that, we don't have as a general exercise program to strengthen swallowing muscles. It would be based on an instrumental evaluation, first of all, because we would want to see exactly where the weakness, if there was weakness, was. A weakness is not the only cause of dysphagia. There's also issues with the motor planning and coordination, sensation, impact of maybe a primary esophageal dysphagia. So know what's impacted of the 29 muscles involved in swallowing before we can prescribe appropriate exercises. I think that you would be the same as whether any other sort of strengthening exercises be appropriate in that population. If we do identify a weakness, what's the likelihood that they'll benefit from exercises? Well, first, they need to be fairly intensive exercises. So they need to be able to complete daily repetitions, usually in excess of 100 repetitions per session, in order to facilitate any sort of change. So can they tolerate that? And if we're looking at somebody who's already, kind of wasting, we see on the swallow study that they have, very depleted muscle mass, and as far as what we can see, and they, their nutritional status is poor, they're nearing end of life, they're probably not going to benefit from strengthening exercises. Probably not. I mean, if somebody is still, wanting that rehabilitative approach, we can try. We approach it with realism, but and optimism. We want to say, hey, I can't guarantee these will work, but we have exercises and we can try them if that, if you want to give it a shot, especially if this is somebody who maybe they've been kind of this tiny old grandma for 10 years, but they've been super functional and they're in with an acute UTI and this is not their baseline. Yeah, we can try some stuff if there's a really big acute component, especially. So kind of a wishy-washy answer, but it's case dependent.
Trying to find the unmute. So like on rounds and everything, I've seen handouts of dysphagia 1 and 2 and various instructions, but I always forget what all those things mean. Other than at the bedside is like chopping the food or making it puree.
Gotcha.
That is, like nectar thick and whatnot. So any high level thoughts about how to keep track of all of those diets? Or textures. I wouldn't say diets, textures.
Yeah. So the dysphagia level national dysphagia diets 1 and 2, otherwise known as pureed and ground minced 3 advanced dysphagia diets, or general, were the previous and very poorly regulated as far as consistency between facilities, that as far as descriptions of diet textures. So this IDSE attempt to standardize kind of across the world really provides ways to test and standardize those textures. And that's what all of our hospitals are moving forward with and advocating in Aurora. So that should be coming. Currently, I would say we're decently, but not perfectly consistent just among Advocate Aurora. And those descriptions, I mean, we have handouts to give to patients based on those diets, but it's all changing. So I don't want to give you too much right now. I would just kind of look to the future, look at IDSE, it's much better.
And I provided the IDSE webpage on the chat.
Yeah.
Thank you so much, Amanda. Thank you for all this. This was really great.
Great. Well,
Really appreciate it.
Anybody has any questions? I'm always happy to talk. I'm a speech therapist, so. All right.
All right. Thanks, Amanda. Bye, everybody.
Bye, everybody.